So today we are going to study about allergic rhinitis. Okay, allergic rhinitis is also a very important disease because it is very common, and there are so many diseases that mimic allergic rhinitis, and and often we see that allergic rhinitis, they are treated as chronic rhinosinusitis or they are treated as acute rhinosinusitis. And the patients, in allergic rhinitis, the patient won't require a lot of antibiotics or any antibiotic at all, but they are being given high doses of antibiotics and other things like that. So it becomes very important for you to diagnose allergic rhinitis. Introduction. It is the commonest chronic disease of mankind in up to 20%. Okay, it is induced after allergen exposure by IgE-mediated type 1 hypersensitivity reaction of nasal mucosa. 30% patients of allergic rhinitis have bronchial asthma. 60 to 80% patients of asthma also have allergic rhinitis. Prevention of allergen exposure is the best treatment. Okay, probably this is one of the most important sentences in all of the class. So we should know that it is very difficult to treat allergic conditions, and what we do is we control them. So the best thing to do, the easiest and the cheapest thing to do is to prevent the exposure of allergens. Okay. Now, what causes allergic rhinitis? Atopy, genetically inherited increased IgE response. Okay, so there's little that we can do about it. Okay, because it is inherited. And okay, there are allergens. Okay, so seasonal hay fever. So this condition, it is usually caused by pollen and fungus, and then so these are active only in particular season. Right? Obviously, pollens, you do not get pollens in all the seasons, especially in the spring. So you get pollens, and do you also get in autumn? No. So mostly in spring. Okay, when they're flowering, the plants they're flowering. Okay. And fungus, especially in these seasons, in the rainy season, in the humid seasons, right? And there are some allergens that are perennial, that are present for all the years, every year, annually, and for several years. So they are the dust mite, domestic pets, cockroaches. So, you know all of them. Okay, dust mite, it is always there. Similarly, domestic pet, if you have cats or if you have dogs or if you have other domestic animals. So there are some allergens, so which are common to these animals. Okay, and cockroaches too. Okay, they are so frequently found in kitchens and the places in the areas of the house where there is water leakage and which is dark and which is humid. And similarly, occupational, yes, this is also very important. So those people who work in flower industries, okay, in animal industries, and those who are woodcutters or who work in furniture or wood saw. And similarly, some people, they are allergic to latex, and some are allergic to paint. So usually the gloves that we use, they are made of latex, and some people, they may be allergic. Some surgeons, they may be allergic to latex, and for them we have separate gloves. Similarly, this is very important. Okay, food induced. There are some foods like nuts, fish, prawns, legumes, milk, cheese, egg, some meats, citrus fruits, and wines. So they can cause allergy, and sometimes these allergies are very severe, and they can also cause anaphylactic shock. So it is not necessary that all of these, food items will cause allergic reaction in everyone. So some of you may be allergic to fish. Okay, it is very common, and some people, they are allergic to nuts. But most of us, like we are not allergic to any of these food items. Drug induced. It is obvious. Aspirin, some NSAIDs, antihypertensive, and OCPs, they can be allergic. And okay, and again pollutions. Okay, so these cause nasal irritation. So the traffic fumes, tobacco smoke, mosquito repellents, perfumes, some scented incense stick. So scented sticks, domestic sprays, and bleaches. Okay, lack of infection. Okay, so we are lucky that we get infected very early in our life. So usually people, so younger child in large families, okay, and frequent viral infection and less prone to allergy. An older child in large family or only child in small family, infection is rare, so develops allergy. So the thing is that in South Asia or in the third world, so we usually live in. So these things has improved, but earlier we used to have larger families, joint families, and the houses they used to be crowded. So when the child is small and in large family, he is exposed to several infections and allergens early in his life, and that is why he develops resistance. And later in his life, he is less prone. So yeah, the Europeans, the Americans, and the people from the first world countries, they are more prone to allergens because they are raised so in isolation, and they are not exposed to infections, and so because of that they do not develop antibodies, and hence they are more prone to infections. So the pollens, like any flowering plants, they will have pollens, and even the grasses, like some sort of grasses they flower, and everything else, like even the trees they flower, and everything that flowers it has pollens. And this is the dust mite. This is the electron microscopy image of the dust mite. So this is how it appears like, right? So what is the pathogenesis? Like any other allergies, so the pathogenesis is mostly the same, right? So this is going to be revision for that. So you must have studied about these things in the pathology class too. So sensitization to specific antigen, inhaled allergen produces specific IgE antibody which gets attached to the mast cell. Subsequent exposure to same antigen. Allergen combines with specific IgE antibody, then the degranulation of the mast cell, even with a small amount of antigen, and then chemical mediators are released. So there are two phases, acute and chronic phase, or early and delayed phase. So acute phase, it occurs 5 to 30 minutes after exposure to antigen due to release of chemical mediators. And the symptoms are sneezing, water rhinorrhea, nasal blockage, and bronchospasm. So mucosal edema and vasodilatation, which will cause nasal blockage. Nerve irritation will cause sneezing and itching. Increased secretion from nasal gland, which will cause rhinorrhea, and smooth muscle contraction that will cause bronchospasm. Okay. So with the onset of exposure of the antigen, so you get these symptoms, and how these symptoms develop. So we have explanation, right? So nasal blockage is mucosal edema and vasodilatation, and simply sneezing. It is by nerve irritation. Rhinorrhea by increased secretion from nasal glands, and bronchospasm by smooth muscle contraction. Now delayed phase or late phase. So it occurs 2 to 8 hours after exposure due to infiltration by inflammatory cells at site of antigen deposition, right? Edema, congestion, and thick nasal secretion. Sneezing and itching decreases. Inflammatory cells are eosinophils, neutrophils, basophils, monocytes, and CD4 plus T lymphocytes. Okay, so this is a diagram. So here you can see the allergen. It is entering the mucosal lining, and here the histamine, the chemical mediators, they are released. And so it goes into the blood vessel, and so these are the inflammatory responses that we get: sneezing, coughing, wheezing, runny nose, weepy eyes, and itchiness. So most of us we have experienced this thing in our lives too. Like whenever we're exposed to cold or in the dusty environment, all of a sudden, just within a few minutes, we sneeze, we cough, and the eyes, like weepy eyes. So tears they roll down the eyes, and there is itchiness. So, and many of us, we develop this in the winter season, like when we are in the blanket and all of a sudden we come out. So the cold, so many people, they are allergic to cold, and so all of this will happen. So what are the most important symptoms of allergic rhinitis? Okay, watery rhinorrhea. Okay, so there is no purulence. Okay, and there is it is not mucoid. Okay, it is not hemorrhagic. It is watery rhinorrhea. So another difference of diagnosis of water rhinorrhea is CSF rhinorrhea, right? So you need to be able to differentiate this rhinorrhea with CSF rhinorrhea. Nasal obstruction, so it is bilateral. That is a small sneezing, 10 to 20 at a time. You know, I have experienced this sometimes, and I'm sure you should have also experienced it, right? Itching the nose, eyes, palate, pharynx. So presence of 2 or more symptoms for more than 1 hour on most days indicate allergic rhinitis. Okay. So if we have occasionally this thing, like suppose we go to some village, and so we roll down the windows of the car, and because of the dust, so we get it. But for next few months, we do not get any symptoms. So we won't call it allergic rhinitis. So this was just on one instance, right? So it should be present on most days and at least 2 of the symptoms for more than 1 hour. And what I mean to say is that whenever there is allergen, we are going to get allergic reactions. That's obvious. But if we stop it, so if we stop the exposure and like we do not have any symptoms, then we cannot call it allergic rhinitis. So it should be present on most of the days and for prolonged time and at least 2 of the symptoms. So what are the nasal signs? So okay, these are the symptoms that the patient will tell you. Okay, like in the OPD, I know. So we have the patients here. They say that okay, naak bata pani tarra bagera huncha. So this is water rhinorrhea. Naak bujjeko huncha bhन्छ हैन in their words. So that is nasal obstruction. And sneezing achuako huncha है. And naak chilaउँछ, कान चिलाउँछ, जताततै चिलाउँछ हैन. They will just एकदम typical हैन. These are the typical symptoms that the patient will tell you, right? Then, as doctors, you need to look for signs, right? So, repeated lifting of nasal tip, right? So, the patient has like blockage or anything like that, and he lifts the tip of the nose like this, right? To make the space, right? So that is called allergic salute, right? To relieve itching and open the airway. So, and this develops in transverse nasal crease, which is called Darier's crease or Hilter's line, right? Our ASMBC students, I mean, you do not have to know this, but it is still good to know, right? Then you have hypertrophic turbinates that are covered with pale or blue foggy mucosa, pitting edema seen on probing. So these are called mulberry turbinates, right? Mulberry also, so that is called mulberry, I know. So imagine how it looks like, right? It has some swellings and some depressions, I know. So these the turbinates, they are hypertrophied in allergic rhinitis, and this should not be confused with any nasal mass like polyp or malignancy or something like that, right? And it is important that it is the mucosa, it is usually pale or blue, and it is boggy. Right? Just when something is laden with water content, right, it becomes boggy. Just like if suppose you have a blanket and if you dip it in water, and what will happen? It will become boggy. So that is what happens with the mucosa, right? And when you probe it, it will depress. Right? There will be pitting edema. Right? So that will that will help you to tell that it is edematous, right? And there is some water content on mucin. So nasal secretions are watery. They are mucoid. Okay, they are not purulent. Nasal polyps with hyposmia and anosmia. Okay, because it's modern polyposis, they are also related to allergy. So the patient may have nasal polyps too. And in case of if model polyp, okay, the AC polyp, enterocorneal polyp, which is not related to allergy. So the nasal polyps, they they are around the model area, so they block the air entry towards the olfactory epithelium, and hence there can be hyposmia and anosmia. So this is what we understand by allergic salute. Many of us must have done this thing in our life too. So nasal blockage of this thing. So we do this to relieve the itching and to trying to open the airway. So because of that, a crease will have developed over the supratip area. So this is the nasal crease or the Darier's line or the Hilter's line. And when we do the enterorhinoscopy, what we see is pale or bluish nasal mucosa, and then there is water rhinorrhea. In cases of chronic rhinosinusitis or acute rhinosinusitis, this area may be filled with yellowish discharge, right, which is pus. And look here, the turbinate is hypertrophic, bluish, and boggy, right? Now inferior turbinate appearance, right? So the pale turbinates, they appear like this, the bluish turbinates, they appear like this, right? And the congested turbinates, they appear like this, right? Because these are the photographic images, right? So this is not actually what you see in the patient, right? Oh yeah, just I have said bluish, right? But in reality, right? Sometimes, right? The turbinates may be nearly of this color that we have seen on our clinical practice. What are the other clinical signs? Frequent twitching of the face, which is called bunny nose, and Dennie-Morgan creases in the lower eyelid skin, and allergic sinus, dark discoloration below lower eyelids caused by venous stasis, right? So all these terms, so it is good to know. So this allergic rhinitis is not important from theoretical point of view, but usually in the practical part of examination, there are some conditions or some questions that are asked related to this, right? Similarly, in the eyes, the conjunctiva is congested with cobble stone appearance, and there is increased lacrimation, right? Ears, there can be ear blockage and decreased hearing due to OME. So what happens? There is stretched tube communicating between the nasopharynx and the middle ear, and because of the tubal occlusion, there can be ear blockage, right? And the tympanic membrane may be retracted, so that will also cause decreased hearing. And similarly, normally the middle ear is filled with air, but in OME there is effusion, there is fluid, and because of that, there can be both this, okay, decreased hearing and ear blockage. Similarly, there can be chronic pharyngitis and laryngitis. Because of the secretions, they may be going towards the oropharynx and over the posterior pharyngeal wall. So this is what we understand by bunny nose, right? And Dennie-Morgan creases, right? Just to give you an overview, right? And this is allergic sinus. So there is the venous stasis below the lower eyelid, and these are called allergic sinus. So whenever you suspect a case, you try to look for these signs, but it's not necessary that all of the patients will have these signs, right? So itching of the eyes, it is very common, and allergic conjunctivitis. So this is called cobble stone appearance. ARIA Classification, ARIA, it means allergic rhinitis and its impact on asthma. So it has classified allergic rhinitis into four types: mild, intermittent, moderate to severe intermittent, mild persistent, and moderate to severe persistent. Okay. So a total of four terms. Okay, mild and moderate severe, intermittent, and persistent. Right? So the classifications, they are based on this, mild intermittent, moderate to severe intermittent, mild persistent, and moderate to severe persistent, right? So when do we call it mild intermittent or persistent, right? Or moderate severe or something like that. So what do we understand by intermittent symptoms, right? So persistent means it is always there, right? So it is present for more than 4 days a week and for more than 4 weeks. So intermittent means only sometimes, not always, right? Present for less than 4 days per week or for less than 4 weeks, right? So this is how we define the duration, the intermittent and persistent, right? And what are the symptoms? The mild symptoms and the moderate to severe symptoms. So in the mild symptoms, all of these should be present, right? There is normal sleep, normal daily activities, normal work and school, normal spot and leisure, no troublesome symptoms. Right? And in moderate to severe, they are abnormal sleep, impaired daily activities, impaired work and school, impaired sport and leisure, troublesome symptoms. So if you have rhinorrhea, if you have sneezing, but that is still causing normal sleep, and you're going to your school or you're going to the hospital, and this is present for only 2 days a week. So this becomes intermittent, mild intermittent, right? Rhinitis. So you have rhinorrhea, you have sneezing, but it is present for 6 months. So this is called mild persistent symptoms, right? And sometimes this rhinorrhea and sneezing, they may cause abnormal sleep, and they are so severe that you cannot go to school and you have to take a day off. Okay, sometimes like especially in my case, and like during the change of the season, I get some, there can be nasal discharge, rhinorrhea, there is sneezing, and all of these symptoms, and and because of that, I may not be able to go to work for 1 day or 2 days. So, but it is only for a few days. So it is moderate, severe, intermittent, right? So you get my point. So we need to find this out so that so is to tailor our treatment according to the diagnosis. Right? So if the symptom is mild, so you are not going to treat it as moderate severe, or if the symptoms are moderate severe, so you should not want to treat it as mild symptoms. Now investigations, right? Sent for absolute eosinophil count, sent for nasal smear examination for eosinophils, skin prick test, radioallergen solvent test, RAST, diagnostic nasal endoscopy, CT scan, PNS for sinusitis and polyps. So we do not do CT scan to look for to diagnose allergic rhinitis, I know. So it is done to diagnose any other conditions which may occur along with allergic rhinitis. So this is skin prick test, I know. So allergens, they are injected and the response is seen, I know. So dust mite, grass, straw, tree. So these are injected. So this is skin prick test, and then the response is seen, right? So the patient's serum is incubated with allergen disc. Only specific IgE binds with allergen. The rest is washed away with a buffer. This incubated with radio-labeled anti-IgE antibody. Anti-IgE antibody binds with allergen IgE complex. Amount of radio-labeled anti-IgE antibody on disc is directly proportional to amount of IgE and is quantified by counting radioactivity from the disc. So that is how skin prick test is done, and so from this we can find out if the patient is allergic to mite only or to the pollen from the shrub or like that. So with any nasal conditions, we always do a diagnostic nasal endoscopy. Right? So diagnostic nasal endoscopy is a part of your routine clinical examination more than an investigation these days. Right? Nose is a dark cavity, it requires illumination, and by rhinoscopy you can see all parts of nose. You may miss a lot of important conditions, right? So whenever there is nasal symptoms or any nasal, you suspect any nasal disease, always go for diagnostic nasal endoscopy. Now, what are the complications of allergic rhinitis? There can be recurrent sinusitis, nasal polyp, serous otitis media, okay, prolonged mouth breathing because there is nasal blockage, bronchial asthma, atopic dermatitis, and conjunctivitis. Differential diagnosis. So you should be able to differentiate from nasal rhinitis. Okay, we'll talk about it later. So rhinitis medicamentosa. So you might have heard this term before, you know. So this rhinitis medicamentosa, it occurs in people who take nasal drop like oxymetazoline and xylometazoline for a prolonged time. So it is also known as a rebound phenomenon. Okay, so this rhinitis medicamentosa is an important question for exam, and usually in OSCE, so you have OSCEs, right? There are 15 OSCEs. So usually you will have one question related to rhinitis medicamentosa. So you give or we give oxymetazoline or xylometazoline, which are the nasal decongestant, hoping to decongest the nasal cavity so that the patient can breathe well. But in rhinitis medicamentosa, it will cause opposite reaction, right? And because of the use of this nasal decongestant, the patient will have further the nasal blockage will be aggravated. Similarly, hormonal rhinitis, okay, it can happen in pregnancy, in hypothyroidism, or by the use of OCPs or contraceptive pills. And yes, as I told you earlier, cerebrospinal fluid, like CSF rhinorrhea, is a very important condition that you need to be able to differentiate from allergic rhinitis, because this is an emergency condition, and if you are not treating CSF leak properly, then the patient may develop meningitis, and which can further, and the patient can further deteriorate. There are several points that will help us to differentiate CSF leak from allergic rhinorrhea. We have another class for this because this is a very important topic, so we'll talk about this later on. Similarly with model polyps. So polyps, they are common with this condition, allergic rhinitis. So small polyps, you may not be able to see them by endoscopy. So always go for diagnostic nasal endoscopy, right? Now treatment. So as with any allergic conditions or allergic diseases, the best treatment is to avoid the allergens. But it may not always be so, right? So, and the pharmacotherapy, so that is what we usually do. And specific immunotherapy, okay, so this is a very important modality of treatment. And sometimes surgery, like endoscopy, sinus surgery to remove the functions of the nose, and turbinoplasty. So there are 3 turbinates usually. And the patient may have the hypertrophic turbinate, which may be causing blockage. So in such cases, the turbinate may be reduced or repaired. So that is called turbinoplasty. Now pharmacotherapy. So we talked something about this in the previous class too, in the treatment of acute and chronic rhinosinusitis. So there are H1 antihistamines. So that it can be the topical elastin, and others are, most of them are systemic. So a nasal decongestant, right? So that we get them in the forms of nasal drops, local nasal drops or topical drops, and they come by the generic name of oxymetazoline or xylometazoline. And some nasal decongestant, they can be systemic, like phenylephrine, pseudoephedrine, chlorpheniramine maleate. So we get these drugs by the name of Sinex, Sinarest, and like that. And similarly, we have mast cell stabilizers like sodium promoglycate, pitotifen, anticholinergics like ipratropine bromide nasal spray. And similarly, we have corticosteroid. Okay, they are very important drugs in the treatment of allergic rhinitis, nasal, oral, terminal, or intramuscular. Right. So leukotriene receptor antagonist, multileucast. Okay, and there are newer drugs like this Aricium MAB 25 and Ultrakinsept. So let us talk about the drugs, the pharmacotherapy that we usually do. Right? Antihistamines and decongestants. The antihistamines are cetirizine, fexofenadine, loratadine, levocetirizine, and desloratadine. So all of these by years we mean systemic, and azelastine is topical. So azelastine is only the topical antihistamine that we know of so far. Like this question was asked in my PG examination. We also have MCQs, and so there was one question on this. And similarly, the systemic decongestant, phenylephrine, pseudoephedrine, and the topical decongestant like xylometazoline, oxymetazoline, and hypertonic saline solution. So antihistamines, the systemic, they come in form of, the cetirizine comes as 10 mg and it is given orally, usually at the bedtime, HS, right? Fexofenadine in 120 mg or 180 mg, and the for children we have also 30 mg and 60 mg. Loratadine, okay, the dosage is 10 mg at bedtime. Levocetirizine 5 mg at bedtime, and desloratadine 5 mg at bedtime. So the topical is azelastine spray. So far in I've not found this in my practice. Azelastine spray 0.1%, 1 to 2 puffs twice a day. Now nasal decongestant. So we have only talked about phenylephrine and pseudoephedrine. They are the components of the drugs like or medicines like Sinex, Sinarest, which we usually take when we have and when we feel that Lapinus boyoi, and then topical decongestant. So this slide is also from a previous class. So Sinarest, Decor, Supreme, Sinex, so they have these three components or combination. Right? Paracetamol is always there, and because of the nasal blockage, the patient will have a headache, and so there is always paracetamol 500 mg, and there is phenylephrine. So these days there are no pseudoephedrine, so only phenylephrine, right? And chlorpheniramine, right? So these act as decongestant and as well as they will relieve the headache, right? So you can take any drug that you like by any brand name. Now, similarly, these topical drops, they, oxymetazoline comes in form of 0.05%, and and there is pediatric dose 0.025%, and also there is for a small child 0.01%, right? So these are given 2 to 3 drops twice a day, and the xylometazoline is in the dosage is 0.1%, 3 drops TTS. This is 0.05 BD, right, for children. And then we have saline drops, right? The commonest drop that we use is NASIVION. We have NASIVION, NASIVION P, and NASIVION yes. So yes stands for saline. Okay, here we have yes. Right? So this is the Allegra, fexofenadine, right? Loratadine, and you may have seen many of these drugs already and used many of them already, right? So this is how, okay, there are different techniques, right? This is the easiest technique, but this is not the perfect technique, right? So nasal spray, these are held like this, and you close one nose and you direct. So when you are spraying it, you spray it towards the eye, the orbit, right? The tip should be directed to that side. The best, technique is to bend forward and then take it. So these are the decongestant tablets, pseudoephedrine, okay, and otrivin. So let us skip this, right? So when you Google for the drugs, you can get so many images in the Google, right? So the corticosteroids, right? So we need to learn about this, right? Because corticosteroids are very important in the treatment of allergic rhinitis. So there are nasal sprays, there are injectables, and there are orals. The nasal sprays that we use are beclomethasone, budesonide, fluticasone, and mometasone. These are the commonly used. And methylprednisolone is the injectable, and prednisolone is the oral drug. So this is fluticasone, and it comes by the name of Flomist, Pyrenees, and like that. Right? So this is one of the drugs that we commonly use in our practice. Right? This is methylprednisolone acetate injection, and this is the Montelukast. Okay. Okay. Now, so pay attention to this slide. Right? So we learned that there are several drugs that can be used, right? But you need to tailor the treatment according to the need of the patient, according to the symptoms, right? So the symptoms are sneezing, rhinorrhea, nasal blockage, nasal itching, and decreased smell, right? So not all of the drugs they act in the similar way, or not all of the drugs they are best for all of the systems, like antihistamines, like I said, levocetirizine and fexofenadine. They are good for sneezing and nasal itching, but not very good for nasal blockage and rhinorrhea. So in the last I told you, last slide, okay, corticosteroids, they are the mainstay of treatment because their response is very good in all of the symptoms, right? In sneezing, rhinorrhea, in nasal blockage, and nasal itching, in all of the symptoms. And so is the response of the oral steroid, and it also helps when there is decreased smell, right? But oral steroid, they have side effects, right? So So if the symptoms are only this and no decreased smell, so we do not use oral steroid. We only give the nasal steroid. And nasal steroids, they are quite safe drugs, right? And chromoglycate, okay, these are not very efficient drugs. And similarly, topical nasal decongestant, look here, okay. So it instantly relieves the nasal drops, they relieve the nasal blockage. And the ipratropium, okay, it will help in rhinorrhea, but not in other symptoms. And the montelukast is also important for nasal blockage, right? So these are the things that you need to know, right? So it is not necessary that fexofenadine will cure all the patients, because montelukast is a new sort of drug, and so better give it, and it will improve everything, right? Now, if specific immunotherapy, right? So here we do not do this, but this is very good. And here the treatment is directed to that particular allergen, right? So what are the indications? Insufficient response to conventional drugs, side effects from conventional drugs, rejection of conventional drug treatment, allergy to one or two allergens only, types, systemic injection, intranasal, and sublingual. So this allergic rhinitis is, it is a very irritating condition, right? And sometimes even when you have used all the pharmacotherapy, the patient may not get improved. And another thing is that by allergen test, if we find that there is one particular organism, okay, allergen, say, okay, fish, or say not, or say any dust, or anything to which the patient is allergic. So why not treat that only that particular condition, and why give the patient so many systemic medicines, right? So in such cases, specific immunotherapy becomes very useful, right? Okay, so now we have less than 1 minute. So what I'm going to do is I'm going to end this meeting and I'm going to restart it and wait for a while you join, right? There are a few such, only 5 or 10 slides left, so we can finish that in next 10 minutes. Okay, this is skin prick test. It is done in. It is usually done in the allergy conditions. Usually the derma people, they also do it. Right? So here we need we do it to find out what allergen is causing the allergy. Right? So there are multiple allergens. We do not do it here, right? But I have a report of another hospital done in India. So one of the patients brought me that. Okay, in the next class or later on, I'll show you that. So they have a list of 70 or 80 allergens. They inject it, and then later on, they see the allergic response. So terminal route is, someone asked me, so it is given through the turbinates. Okay, so these are the indications for specific immunotherapy. So injectable specific immunotherapy, serial subcutaneous injections of immunogenic extracts from relevant allergen in increasing concentration. Right? So this treatment modality is not very important for you because as MBBS you're not going to do this, right? So you should be well aware about the pharmacotherapy that you need to that you're going to need your practice, right? Injections given twice weekly until response is noticed for 6 to 20 weeks and given weekly for 1 year and then fortnightly. So this treatment is for a prolonged time, right? So intranasal and sublingual specific immunotherapy can use 50 to 100 times greater doses compared to injection immunotherapy considered in selected patients with systemic side effects and refusal to injection treatment. So this is just for an overview. Now this is important, right? Treatment protocol. So the treatment is, let us go to this slide. This slide. Okay, so treatment is avoidance of allergens, pharmacotherapy, specific immunotherapy, and surgery. So avoidance of allergens, we all know it, and I'll also explain it to you in the final slides. So as MBS student, this pharmacotherapy is very important for you because based on the symptoms, Okay, based on the symptoms, you should know which drugs you should give, right? And it is not necessary that we see that in the periphery, people always give the Allegra or the fexofenadine, but that may not treat the conditions, right? So you need to know what drugs are effective in what conditions, right? So this one particular slide that you need to know in your practice. And so this specific immunotherapy, it's just to let you know that. So there is some sort of therapy like this, where if you know one particular allergen, the therapy is directed to that. So the treatment protocol, mild and intermittent, right? So the symptoms, they are present for less than 4 days a week and for less than 4 weeks. And the symptoms, they are not debilitating. Okay, you are going to be able to go to school, you're going to go to work, just sleep at the stop. So here you give H1N histamine and Decongestant. And even if there is no improvement in the treatment, so you need to treat it as moderate to severe intermittent. In case of improvement, so you step down the therapy and then treat for further 1 month. Moderate, severe, intermittent, and mild persistent. So here you give a drug like levocetirizine and nasal drop, and then you also add corticosteroid treatment. So if there is no improvement after 1 month, even with corticosteroid nasal spray, so you double the dose of corticosteroid, and you can add ipratropium for rhinorrhea, and chromoglycate for seasonal cases, and montelukast for asthma. And even if there is no improvement after 1 month, then we need to refer the patient for specific immunotherapy. Now, moderate severe persistent, right? So you give something like Allegra and the nasal drop, and double dose of like flutic acid nasal spray, and also montelukast. So if there is an improvement after 1 month, then we can add oral corticosteroid, right? And similarly, if there are polyps and terminates are enlarged, so in such cases, surgery can be done too. And again, if no improvement, so there are chances of no improvement of treatment even after 1 month. In such cases, you need to refer the patient for specific immunotherapy and other newer forms of drugs that we have not used here so far. Now, general advice. So this is the most important thing, right? Avoidance of the allergen, pharmacotherapy, switch immunotherapy, right? And surgery. So the general advice is avoid cold drinks, ice cream, and very cold air, right? Because our body is made, like our body, it doesn't have a very large range when we're exposed to temperatures. So we cannot tolerate very cold temperatures, and we cannot tolerate very high temperatures. So avoid these things if you have symptoms. But if you don't have any symptoms, then just enjoy ice cream, enjoy cold drinks, right? And enjoy going out in the cold places. And as it is obvious, okay, cigarette smoke, it is not going to do any benefit to you. And it is very difficult to avoid traffic fumes. But okay, now we are already habituated with a mask. So always get on the mask when you're going out in the towns, in the downtown, and in the current congested cities like Kathmandu. Okay, the air in Chittagong is relatively much better, but we still have some dust. So avoid strong perfume, scented sticks, and other cosmetics. Avoid head bath with cold water. Okay, use water. This is one advice that we give to patients, right? So in all seasons, if it is possible and if it's so tolerable, get a warm bath, right? Avoid mosquito repellents and bleaches. Okay, the easiest thing to do is get a mosquito net, right? So no chemicals, no any side effects, no allergies. Get the mosquito net. So have a balanced diet to improve body immunity. Okay, this will help in all the conditions where immunity is better. So you are resistant to a lot of conditions. So sleep with head elevated to decrease nasal congestion. Adequate fluid intakes to loosen nasal secretion, right? So drink a lot of water, around 3 to 4 liters every day, and according to the work that you do and according to your climatic condition, right? So these are the general advice, right? And also exercise regularly. So that will help you to improve your immunity, right? That will make you stronger. And avoid foods and drugs to which you are allergic. Okay, is obvious. Okay, So the nuts, right? Different nuts, like groundnut, peanut, or some walnuts. So many people they are allergic to particular nuts, and some people, usually the people from the first world country, they are allergic to some fish, and there are many people who are allergic to seafoods, right? So once you develop allergic reaction to some food, okay, just avoid this, right? There are so many varieties of food available. So if you start taking one particular seafood or one particular nut, so it is not going to harm you. But if you must take that food, then you need to go for specific immunotherapy. So avoid occupational irritants or change the profession. Okay, some people who work in the wood industry, okay, they may develop allergic rhinitis due to the wood dust. So okay, so just try to avoid it, but many times it becomes difficult to avoid occupational irritants, and it becomes very difficult to change the profession. But sometimes when it is disturbing your health, it is disturbing your daily activities, then even you should consider changing the profession, right? Because nothing is more important than health. Remove furred animals like cats, dog from bedroom. Wash the pet weekly with warm water, right? So it is only if you are allergic, right? If you are not allergic, then just you can play with your pet animals. But even when you have it, you always wash it and clean it in the pet animals, right? Because these furs, you know, they are the dust magnet, right? And they just you know attract dust particles and other allergens. So keep the bathroom, kitchen, basement, and the attic area clean, right? So we usually do not have attic in our setup. Right? Usually in Europe, in UK, so you see the house which has the topmost part of the house. I know. So that is called the attic. So this attic is also used in ear. So this comes from the house. The attic word in the ear comes from the house. So the topmost part of the middle ear is the attic. And these areas which are lesser cared for, so we need to clean them and keep them ventilated, right? So we usually clean our bedrooms and the living areas, because those are the areas that are mostly used. But these areas, so we are careless about these areas, so they need to be cleaned too. And similarly, use insect repelling chalks, avoid sprays, avoid collection of spilled food materials, right? So these days we have heat and other bacon and things like that. So you may get allergic to that. So there are special insect repelling chalks, right? एउटा चाहिँ पाउँछ हैन लक्ष्मण रेखा भन्ने हुन्छ हैन so this can keep the ants and other insects out, and that is also not allergic. Pollen advice, right? Avoid walking in open grassy spaces during hot days, right? Move outdoors only on damp days. Hot days, what happens in the hot days? The pollen side, they will be in the air. On the damp days, they will at the bottom of the on the ground, right? They're near to the ground, so you don't get affected in the damp days. So keep the windows closed, right? Move flowering plants away from doors and windows. Wear face mask and sunglasses when moving out. Okay, face masks you have already been using, and you can also use things like this, face shields, right? And other sunglasses. So keep grass and plants trimmed, get rid of weeds and leaves, and so, and if you must have plants, then plant less allergic flowers and trees. Okay, how's dust mite advice? So how will you just improve it, right? So use foam pillows and mattresses with dust-proof covers. Right? Remove carpet, upholstered furniture, stuffed toys, old newspapers, and magazines. Okay, so we have tendency to keep the old newspaper magazines, right? But over time, I know they collect. They have mites there, dust mites. They collect dust, and there is mites. Similarly, upholstery means there are some. It means some furnitures that have a covering, like fabric they're covering it. They have fabrics, right? So just use the furnitures that do not have any fabrics and which is easy to wipe, right? And the carpet needs to be removed. Similarly, the bed covers and the cloths, they need to be washed in warm water. And so, so you need to clean. Do not just dust the house, but wipe it, right? And when you're doing that, use a face mask and use vacuum cleaners with high efficiency particle arresting filters weekly. And better to use air conditioner, because if you keep your windows shut, the smell of the room will become bad. So better to use air conditioning and use the pollen filters. These days, most of them have the pollen filters, and these days you can also control the humidity of the air conditioners, right? I think. Okay, so that was the last slide, right? Yeah. So why I focused on the control of the allergens, because this is one of the methods which will help to improve the systems without the use of without spending any money, right? So, and it is obvious when something is irritating you, just try to avoid that, but that may not always be the case. So in such cases, as MBS doctors, you need to be able to administer the therapeutic drugs, right? Like the H1 antihistamines and the corticosteroids, right? And make sure that if the patient is not improving, you refer him timely to the nurse center, right? Okay, so this is the end of the class, right? So I hope you have understood most of the points. And so still the most important thing is, because this has been made as a separate class, because this is a very common condition, and you need to separate it from acute rhinitis, chronic rhinitis, nasal polyps, right? And as you have seen, we are not giving antibiotics, right? Antibiotics have no role in allergic rhinitis. In the periphery, we see that they give a coverage of antibiotics. But if you are able to diagnose a case of allergic rhinitis, so why make the patient resistant to antibiotics? Right? Why antibiotics are quite expensive too? Why spend the money? Right? So okay, then if you have any questions, then you can ask me, or if you don't have any question, then just I can finish it here. So it has already been nearly 1 hour. Okay then, class. So you have a good day.